Good morning. And welcome to today's Seinfeld. Let's bring it to the table. What did you notice? What did you observe in last night's Seinfeld episode, The Cadillac?
So like George, he's trying to cheat on his fiance, and that kind of goes back to George being chronically insecure, feeling like the grass is greener on the other side, external validation, and like trying to rationalize it throughout the whole thing.
What's the motivation that he provides in trying to cheat on his first girlfriend? If you ask George, if you picked it up from the episode, what's going on here?
Well, I guess he says that like just getting coffee isn't really cheating. Or I guess it's like if he considers emotional cheating different than physical cheating.
Right.
So George, I actually forgot your question. What your question say again? Sorry.
Just the evidence from the episode itself as to why he's doing what he's doing.
Like I said, he wants to be validated. George is like surprised at what are the odds that a woman can want someone who's specifically like him, like short, quirky, and what is it? One other stocky. I think he said 12, and he's just like, and she's a Oscar-winning actress. He's like, this is one chance. With what are the odds? He has to pursue that. So I think he feels very lucky. So that's why he has to do that.
Any other observations here?
I think going off that, it highlights a lot of his insecurities that prior to knowing that a famous person may be interested in him, he was secure in his relationship, and just hearing one sentence made him want to not only leave his relationship, but start dating this other woman and starting lying to other people. Like, just one sentence probably shouldn't cause that much to happen, but because he's so insecure, and I think he gets external validation. Like if I was dating a famous movie actress person, then that would make me better, type of thing.
Mm-hmm. And I completely agree with you, and I think that motivation has to be weighted against his current relationship, which clearly he's not emotionally vested in. Because all that could be true, but if you have found your soulmate and if you vowed to spend the rest of your life with them for better or for worse, that first part should not impact what you're already the relationship you're already in, but it clearly does. Which then brings us to what might be really going on here, and that is George Costanza, over the 9 seasons of Seinfeld, has really never been in a relationship in which he's truly cared. It's all been superficial.
I also want to mention that we all, I mean, if you watch this show, you already know that this is not his soulmate. So it's easy for whoever's watching to understand why he went the way he went so quickly, number one. And number two, he mentions to Jerry, if you guys are familiar with the show, that we had a pact. So it's not necessarily that he's getting married because he loves someone. He loves Susan. It's because he and Jerry were supposed to make this little pact for both of them to get married. It has nothing to do with love. It was the status of getting married and doing this with Jerry. And if he loves anybody besides himself, it's Jerry, because that was the pact that he had with his friend, as opposed to Susan.
So that's the only reason that they got engaged.
Yeah. It was not a chance meeting, but it was one of their routine meetings at Monk's, where they both kind of stopped each other and said, what are we doing? I mean, we're middle-aged and we're acting like children, little boys. We really have to take inventory and take charge of our lives. You know what? Enough of this. And they decide they're going to be more mature. And they both end up meeting women and realizing this is it. And Jerry was like, well, second thought, nah. Yeah. So they had a pact. And again, I bring that up only because the pact, the actual conversation really gets at the core of what we just talked about. How he's very superficial, because the superficiality was something that was so overwhelming at that encounter out monks that they even realize that, and we've got to stop this. We've got to really do something different with our lives. You know, we're going to be 80-year-old men talking about the same things. Other behaviors in last night's episode.
It's the tall guy, Kramer.
Kramer.
Yeah, he has like this trauma from the cable people not coming at the times they say they will. So he spends the episode getting revenge on the cable guy.
Yep.
It's like bizarre and a bit obsessive. And then it's ironic because like the cable guy obviously wants to service him, which would solve his issues, but he's so fixated on being vindictive and getting revenge that he doesn't ever get any help.
Oh yeah. Yep. That subplot with Kramer, what is it an allusion to? Was that
Projection or generalization? I thought it was about.
could be generalization, sure, but it's actually an allusion to a novel.
Oh, Moby Dick.
Yeah.
Oh,
Yeah. Yeah. Did they mention white whale in the conversation? I might be actually adding that in, but yes, it's an allusion to Moby Dick. So a brief tangent here. What's Moby Dick really about?
This captain that has his lifelong essentially beef with a whale that he like has been trying to conquer and like I think has killed like his past crewmates, and his Moby Dick is the cable company.
Yeah, I think if you read most essays about Captain Ahab, they'll talk about the quote unquote monomaniacal captain with severe obsessive compulsive disorder as a result of that obsessive thought, that intrusive thought of wanting to get back at Moby Dick. And that might be true, but there's another condition also within the anxiety disorders in which intrusive thoughts are the hallmark quality, and that's post-traumatic stress disorder. And the fact that Moby Dick took Ahab's leg suggests that there was prior trauma, and that's certainly on our differential. But most people will actually look at the whether it's the film, whether it's the novel in which it is based, as a case of obsessive compulsive disorder, and clinically significant too, because he puts himself and his entire crew, you know, in danger as a result. Right. Similarly, it's a remake of Moby Dick, premiered in 1975, which is also about significant post-traumatic stress and intrusive thought about getting back at a fish for what happened to him prior. Jaws. Yeah, Jaws is the remake of Moby Dick. And for anybody sitting around this table, and apology for anyone sitting around this table who's going to our medical school, our Rutgers University or state school, who is not from the state, apologies ahead, but the reason to watch Jaws is because it is also based not only on Moby Dick as a remake, but on the 1916 shark attacks down the shore. Right. So it's real life horror, right? That actually happened. I'll leave Jaws and Moby Dick to you guys. Certainly, we're way off season to talk about Jaws. That's a July 4th weekend thing. So we'll get back to Seinfeld. Anything else about Kramer you've noticed? How do you treat obsessive compulsive disorder? So let's say Kramer and Kramer's behavior comes to your clinical attention, and you deem that it is significant, that it's resulting in clinically significant distress or impairment in Kramer's functioning.
Exposure and response.
Yeah, so I refer to you, right, for those big words. This is a form of behavioral therapy, exposure therapy, response prevention. And that's got to be the core of this. Again, quick raise of hands, and I think I already know the answer to this, so deep breaths. How many people here are going into psychiatry? Oh, okay. Wow, you know what? I take it back. Maybe it was the last rotation. Boo on them. It was like not a single person. For the rest of the crew who did not raise their hand, number one, I still have a couple weeks to convince you otherwise. Number two, if you do go into a non-psychiatric field, you're going to treat a lot of anxiety and depression, right? 80% of individuals with anxiety and depressive disorders actually go see their primary care psychiatrist or another physician other than a psychiatrist. So be ready. And in teaching anxiety or treating anxiety, and I hope this resonates so you never forget this, every quarter you should do a quick inventory of your entire patient load. And the number of those patients that you do not refer to psychotherapy should always equal 0. Everyone with anxiety, the anxiety disorder, gets referred to psychotherapy. That's got to be the core of any biopsychosocial treatment plan. Some of whom will also be put on medications, right? And certainly the medications that you start with here are the SSRIs, but there are other non-SSRI medications that are also first line and FDA approved to treat OCD as well, right? And there's also second line medications, and because they are second line, you better know them for your shelf, right? So what is the one second line medication for obsessive compulsive disorder that is almost guaranteed? 50-50 of being on a shelf exam. Good. Clomipramine. Yep. It's a tricyclic, FDA approved for not only depression, but OCD as well. Clomipramine. And then being prepared to take your shelf exam, what are the 3 necessary ingredients, if you will, points in your clinical vignette that will allow you to choose that second line agent?
Did the first line fail?
Good. That's it seems intuitive, but say it out loud. First line agents have been unsuccessful, and usually in the vignette, there's been 2 trials. One trial, you retry, different medication, same class. So you go from sertraline to fluoxetine, right? 2 trials unsuccessful. Good. What other?
Maybe they have a history of mania, so you can give this.
In either case, you're gonna tread lightly. That's not gonna point you towards a second line versus a first line.
Is it like side effects?
Not side effects. Good thought though, because that's why they're second line. I'm going to give you that answer. There's an absence of contraindications, right? And this is tricky on a shelf exam because they're not going to list a whole bunch of things that patient does not have heart disease, patient does not have D, E, F, G. They're not going to list that. They're going to present a patient as being what, in which your reaction is going to be, oh, they're healthy.
Young,
And
fit.
and
With no other conditions.
female. Young females are the operationalization, say that one quick, of health. In the absence of any lab results or physical exam findings, you could assume health. So 21-year-old female presents, and that's healthy. The other one, again, fairly intuitive. The other point here is that there must be an indication. And unfortunately, you're likely not going to see major depression. You're going to see obsessive compulsive disorder. This is the board testing you of your knowledge of that alternate indication of OCD. So a 21-year-old female presents with severe OCD for which she's received trials of SSRI number 1, SSRI number 2, single next best step is clomipramine. All right. Other plot lines, other characters.
There's definitely like a parallel between I guess like George kind of being attracted by this like shiny thing, which is like Marissa Tomei, and then Elaine like suddenly being like attracted by this shiny thing, which is like finding out that Jerry has like the means to buy like a Cadillac and stuff like that. And I mean, I feel like it is kind of just like human nature, like a gut reaction. Like if you see something like grass is greener or something that we've been taught like doesn't have any downsides, like money or like a glamorous actress or something like that, to kind of like immediately have that gut like kind of like longing for something or yearning. Like even this week we had like a pain specialist, like an anesthesiologist, and he was like kind of telling us, the students, he was like, yeah, I have like job offers that are like $650,000 and like lots of vacation and stuff. And he's like, I can feel the tides changing in the room, kind of saying like just that superficial saying, like listing the amount, the time off, and suddenly people are like, oh, like I'm never gonna make that much, like I'm gonna work way harder for the same amount or stuff like that, even though like within a day we all go back to like separating the signal from the noise and knowing like what we want. But like in that moment everyone's kind of like like pulled by these like shiny things. So like
Absolutely. So I like the way you started it with it being basic human nature, because what you're getting at is personality and personality development, right? I think everybody's well aware by now that there are positives and negatives in everyone and everything, as well as every place. And I think part of therapy is to come to a cognitive awareness that you've got to either focus on that positive or train your brain to focus on the positive and not be a splitter. you have to live in the ambiguity and the ambivalence, and to the extent somebody can, or to the extent somebody unconsciously does, that is a protective factor against future mental illness, especially anxiety and depression. It's when you can't. It's when you hear stories like this that begin to focus you on one, the black versus the other, the white, that you begin to create anxiety. And if that becomes who you are, i.e., if you adopt splitting as an unconscious process that is your rigid defense 24/7, that's now not a protective factor. It's actually the opposite. It's a risk factor for mental illness, not only the personality disorders, but again, anxiety and depression. And I think that's what we're seeing here. None of these characters are comfortable with the ambiguity, the ambivalence of the gray that is all of our lives. It's one or the other. And if their mind automatically goes to, let me find the negative in this, again, unconscious process, they're going to have no problem doing that because everything and everyone has a negative quality to them. That's a big part of therapy, is to unlearn that, right? Unlearn that. So I think that's what you're seeing here.
Yeah, it's like ironic that at the end, like the shiny things are the things that kind of disrupt people's lives the most. Like he ends up getting impeached and like removed from his condo and stuff like that. And then like I guess like I don't watch Seinfeld, so like I was kind of assuming that Susan and George did have like a fine relationship, and this was just like a rough patch. So I kind of thought like, oh, like now this is pulling him out of something good, and like on the other hand, then for the money, it's pulling them out of something they like.
You know, it's interesting you say that because even though their relationship, this is Susan and George, is not that. It's not. The fact is if it were, this would have the same outcome and result,
Yeah.
because it's George that is a common variable here. So it really doesn't even matter how strong the relationship is. Sure, it's weak, and now we can say, oh, that's why. It's not why. We see this, that is George's quality, his personality, as really being the core to what's important to understand in terms of any treatment planning that we might actually consider. Yeah, that's the variable, and that I feel confident that it would be the same exact intensity with the same exact outcome, even if that relationship were in fact strong. So, okay, we'll leave it there. The other thing I want to just mention, I'm tempted to stop the recording, but not. I'm not sure I know how. But your comment about the 650, I will tell you right now. All right, and this is incredibly prejudiced. It's biased, but I'm going to say it anyway. Those salaries often come without interaction with learners and trainees. And while it is true, it is significantly higher than an academic medicine / psychiatrist career, I could tell you that it is so boring. And the last thing you do in the morning is get up looking forward to your day, right? So incredibly biased, but if you're going to go into academic medicine, sure, you're going to take a pay cut. But I'm going to tell you, in terms of lifestyle and quality of life, quality of academic and teaching life, it is worth it. Right now, if you want more detail to that, I'd be more than happy to provide academic counseling and advising. But let me just make that mission statement too. All right, so we'll end on that hopefully positive note, albeit biased, but positive note.